Welcome to this clinical education session on open abdominal aortic aneurysm repair or open AAA repair. Today we will cover the essential nursing considerations from preoperative preparation to critical postoperative assessments and management. This procedure remains a cornerstone of vascular surgery, requiring precise nursing coordination and vigilant monitoring. Our goal is to equip you with the knowledge to provide high-quality, evidence-based care for these complex patients. Let's begin with a review of the anatomy and the pathophysiology of abdominal aortic aneurysms. The abdominal aorta is the largest artery in the abdomen, supplying blood to the major organs and lower extremities. A healthy aortic wall consists of three distinct layers, providing the structural integrity needed to withstand high-pressure blood flow. An aneurysm occurs when a segment of the aorta becomes weakened and dilates, often exceeding 50% of its normal diameter. Most abdominal aortic aneurysms are infrarenal, meaning they are located below the origin of the renal arteries. Chronic inflammation and degradation of elastin and collagen in the aortic wall are primary drivers of this dilation. As the diameter grows, the risk of a life-threatening rupture increases significantly, necessitating surgical intervention. While most AAs are fusiform and symmetric, saccular aneurysms can also occur, presenting unique surgical challenges. The change in vessel geometry leads to turbulent flow, which can promote thrombus formation within the aneurysm itself. Surgical repair is typically indicated when the aneurysm reaches a critical size or shows rapid expansion. Advanced imaging like CT angiography is essential for precise surgical planning and patient selection. Many patients are asymptomatic, but a pulsatile abdominal mass or persistent back pain can be key clinical red flags. Ultrasound screening is a cost-effective method for early detection in high-risk populations. In the event of a rupture, patients present with a classic triad of severe pain, hypotension, and a pulsatile mass. Ruptured AAA is a surgical emergency with extremely high mortality rates, requiring immediate transfer to the OR. While ultrasound is great for screening, CT angiography provides the detailed anatomy needed for open repair. The decision between open repair and endovascular repair depends on the patient's anatomy and overall surgical risk. Open repair is a more invasive but definitive procedure, often preferred for younger, lower-risk patients with complex anatomy. The primary advantage of open repair is its long-term durability and lower rate of secondary interventions. Preoperative preparation for open AAA repair is intensive and focuses on optimizing the patient's physiological status. Cardiac optimization is paramount, as many patients have underlying coronary artery disease. Basal renal function must be established as the kidneys are at risk during aortic clamping. Nursing responsibilities include ensuring NPO status, verifying consent, and confirming the availability of blood products. Pulmonary preparation, including teaching incentive spirometry, helps reduce post-operative respiratory complications. A thorough baseline assessment of peripheral pulses is critical for post-operative comparison. Surgical site infection prevention begins with rigorous skin preparation protocols. Addressing patient and family anxiety through clear education is a vital part of the pre-op nursing role. Strict adherence to medication protocols, such as continuing beta blockers, can improve cardiac outcomes. Now let's transition into the intraoperative phase to understand the surgical steps and their physiological impact. The open repair involves a large midline abdominal incision to gain direct access to the retroperitoneum. General anesthesia and invasive hemodynamic monitoring are standard for this major procedure. Once the aorta is exposed, the surgeon carefully mobilizes the vessel above and below the aneurysm. The most critical intraoperative event is the application of the aortic cross clamp. Clamping immediately increases afterload and can cause significant hypertension and cardiac strain. The anesthesia team must aggressively manage these shifts to prevent myocardial ischemia. The surgeon then opens the aneurysm sac and sutures a synthetic Dacron or PTFE graft to the healthy aorta. Precise suturing ensures a blood-tight seal, restoring the integrity of the aortic lumen. Declamping is equally critical as it can lead to sudden hypotension and reperfusion injury. Restoring flow releases metabolic byproducts like lactic acid and potassium into the systemic circulation. The surgeon meticulously checks for any anastomotic leaks before closing the aneurysm sac over the graft. If the aneurysm involves the iliac arteries, a bifurcated graft is used to restore flow to both legs. Managing significant blood loss is a team effort, often involving cell-saver technology and rapid infusers. Once hemodynamically stable, the patient is transferred directly to the intensive care unit. The first 24 to 48 hours in the ICU are the most critical for nursing surveillance. A structured handoff is essential, focusing on intraoperative clamping times and fluid balance. Continuous hemodynamic monitoring via arterial and central venous lines is mandatory. We target a specific blood pressure range to ensure graft patency without stressing the suture lines. Vasoactive drips are titrated carefully to maintain this delicate hemodynamic balance. Frequent neurovascular checks of the lower extremities are performed every hour initially. Assess for the 6 Ps to detect early signs of distal embolization or graft occlusion. Hartley urine output is the most sensitive indicator of renal perfusion and aortic clamp recovery. Notify the surgeon if urine output drops below 30 milliliters per hour, as this may indicate AKI. Monitor the surgical dressing and drains for signs of hemorrhage or hematoma formation. Pulmonary hygiene is prioritized to prevent atelectasis and pneumonia in the post-extubation phase. Effective pain management, often via epidural or PCA, is crucial for early mobilization. Auscultate for bowel sounds, as paralytic ileus is a common occurrence after extensive abdominal manipulation. Be vigilant for bowel ischemia, signaled by bloody stools or an unexplained rise in serum lactate. Early mobilization is a key component of the Enhanced Recovery After Surgery or ERAS protocol. Watch for signs of infection, including fever or increasing leukocytosis at the incision site. Cardiac monitoring continues to detect silent myocardial infarction, a significant risk in the first 48 hours. Maintaining tight glycemic control supports wound healing and reduces the risk of infection. Meticulous fluid and electrolyte management is required to handle the large volume shifts from the procedure. Ensure deep vein thrombosis prophylaxis is initiated as soon as it is surgically safe. Psychosocial support remains a constant throughout the recovery process in the high-stress ICU environment. Let's summarize the major potential complications we must be prepared to manage. Graft infection, while rare, is a devastating complication requiring prolonged antibiotics or further surgery. Distal embolization or trash foot can result from debris dislodged during aortic manipulation. Spinal cord ischemia is a rare but catastrophic complication, especially if the clamp was placed high on the aorta. Nurses must perform detailed lower extremity neurochecks to identify any new motor or sensory deficits immediately. Abdominal compartment syndrome can occur due to massive fluid resuscitation and tissue edema. Monitoring intra-abdominal pressure via a bladder catheter helps identify this life-threatening condition early. Myocardial infarction remains the leading cause of early postoperative mortality in open AAA patients. Respiratory failure due to the large incision and prolonged anesthesia requires aggressive pulmonary nursing care. Wound dehiscence and incisional hernia are long-term risks that start with poor early wound healing. In summary, open AAA repair is a high-stakes procedure that demands exceptional nursing vigilance. Success depends on your ability to recognize subtle changes and intervene early in the recovery process. Focus on hemodynamic stability, distal perfusion, renal function, and pulmonary hygiene as your core priorities. Your role as an ICU or vascular nurse is vital to the long-term positive outcomes for these patients. Thank you for your dedication to clinical excellence and for participating in this education session. Please refer to your hospital-specific protocols for additional guidance. Good luck with your practice.